Therapeutic ultrasound generally refers to any type of ultrasonic procedure that uses ultrasound for therapeutic benefit. The first large-scale application of ultrasound was around World War II, when submarines were using sonar systems to navigate. But after it was realised that the high-intensity ultrasound waves being used were heating and killing fish, research was conducted into its tissue heating and healing effects. Physiotherapeutic ultrasound was subsequently introduced into clinical practice in the 1950s and has been in use, albeit in varying amounts, ever since. To create ultrasound, voltage is applied across a piezoelectric crystal, which causes it to change shape. A transducer is placed in contact with the crystal, and as the crystal undergoes a change in shape, the metal of the transducer moves backwards and forwards, producing a series of high-frequency ultrasound waves. Gel is used on the surface of the transducer head to reduce friction and assist transmission of the ultrasonic waves, which typically have frequencies between 0.7 and 3.3 MHz. Lower frequencies are used for deep tissue penetration, while higher frequencies are used for superficial structures. Ultrasound can be applied continuously or in pulses. Continuous ultrasound is associated with thermal effects, which we discussed in the lecture on therapeutic heating, while pulsed ultrasound is associated with non-thermal effects because it allows for heat to dissipate in the tissues. The short bursts of pulsed ultrasound can be in different ratios. For instance, 1:4, which is used for acute injury, or 1:1, which is used for chronic injury. Ultrasound can also be applied at different intensities. Intensity is the rate at which energy is delivered per unit area and is expressed in watts per square centimetre. Lower intensities, 0.1 to 0.3 watts per square centimetre, are typically used for acute injuries, while higher intensities, 0.5 to 0.9 watts per square centimetre, are used for chronic ones. When calculating the overall treatment time for ultrasound, the principle of 1 minute multiplied by the number of times the treatment head of the transducer fits within the injured area, multiplied by the pulse ratio, is followed, within the constraints that overall daily treatment time should not exceed 10 minutes for continuous ultrasound or 15 minutes for pulsed ultrasound. So for instance, in treating a 26-year-old soccer player 24 hours post right knee MCL strain, the frequency of ultrasound applied would be 3 MHz because the MCL is a superficial structure. The pulse ratio would be 1:4 with a 20% duty cycle, and the intensity would be 0.2 watts per square centimetre because the injury is acute. The head of the ultrasound machine fits over the treatment area just once, so the treatment time would be 5 minutes. Ultrasound is often used for conditions like ligament sprains, muscle strains, tendinitis, joint inflammation, plantar fasciitis, metatarsalgia, facet irritation, impingement syndrome, bursitis, rheumatoid arthritis, osteoarthritis, and scar tissue adhesion. There are lots of contraindications to using ultrasound too, and these are summarised on screen. But does ultrasound actually work? Simply put, there is little evidence that active ultrasound is more effective than placebo treatment for treating patients with pain or a range of musculoskeletal injuries, or for promoting soft tissue healing. For instance, a systematic review of 13 randomized controlled trials of patellar tendinopathy patients concluded that, based on the limited available evidence, ultrasound should probably be excluded as a treatment option for this condition due to its marginal efficacy. Another systematic review of randomized controlled trials in lateral elbow tendinopathy found insufficient evidence to support or refute the effectiveness of ultrasound as a lone treatment. And another systematic review for rotator cuff tendinopathy found therapeutic ultrasound to be inferior to laser therapy and of no greater benefit than placebo. And then another single RCT comparing hyperthermia treatment or heat therapy to continuous ultrasound in patients with either Achilles or patellar tendinopathy concluded that ultrasound treatment was actually inferior to the physical modality of heat. Ultrasound is also considered to be unproven in the treatment of carpal tunnel syndrome, acute ankle sprain, and plantar fasciopathy. This is just a brief summary of the available literature, and I've tried to be quite selective by only citing systematic reviews and randomized controlled trials. That's not to say that there isn't any research showing some kind of benefit to ultrasound treatment. For instance, one study showed a more rapid resolution of calcific rotator cuff tendonitis with ultrasound compared with exercise. That said, there was no difference between the groups at 9 months. The issue is that these kinds of studies represent a minority and are generally of low methodological quality. For example, treatment groups are generally not randomly allocated, groups are not blinded to whether they are receiving treatment or some kind of sham, nor are the investigators blinded to group allocation. There are lots of missing data, participants are lost to follow-up, and the dose of ultrasound given to participants varies widely, often for no discernible reason. Finally, none of the positive results are well replicated in follow-up studies. So in summary, there is little evidence that ultrasound is more effective than placebo treatment for treating patients with pain or a range of musculoskeletal injuries, or for promoting soft tissue healing. And that concludes this lecture on ultrasound, where I gave you a brief overview of its history, how it is applied, including how to calculate certain treatment parameters, and the contraindications to it. I then summarised the evidence or lack thereof for using ultrasound in the care pathway.